All right, guys, it's the top of the hour. To respect everyone's time, I think we'll get started. It's great to be back doing another MAVA, another multidisciplinary approaches to vascular anomalies. It's been a long time. I can't say we were so productive in producing these webinars during the pandemic times, but if we can all get to Madrid for an ISFA conference, we could probably do webinars again. So great to be back here and see some friends again and discuss some multidisciplinary cases. We're really excited and we're really thankful to the Hendren Project to bring us together again. All right, so why did we create MAVA in the first place? Well, I mean, this is a great opportunity in between ISFAs and some sub-meetings to come together as a community and talk not just nationally, but internationally about some of the cases and try to advance our field. We really want people of all disciplines to have an awareness of vascular anomalies. We want to see if we can have some sense of standardization and approach. I know that's difficult, but at least debate standardization and approach, speak the same language, you know, kind of when it comes to diagnosing and treating these conditions. And just these were designed to have good debate amongst colleagues, healthy debate to kind of advance the field. So thank you all for joining us. As mentioned, most of the people probably in the audience and on the panel are members of the International Society for the Study of Vascular Anomalies. Anyone who has been part of this group knows it's probably the one international community we have to come together despite your field, your subspecialty, and have a common ground where we try to come up with the same discussion and classification. As everyone likely knows, it's a work in progress. Every year or every few years, the classification system for ISFA is updated as, you know, what one person thinks is a duck and one person thinks is a chicken sometimes looks like a duck chicken, you know, in the clinic, and it's really difficult to know exactly what things are. But if you were to subscribe to the ISFA classification system and think about today's presentation, we will probably be leaning towards the vascular tumor side. And of the spectrum of benign to more malignant type vascular tumors, we will be probably leaning towards the benign lesions today. And yet it's a funny term to use when likely most of the discussion will talk about benign lesions, vascular tumors that are causing a significant functional impact on the child that's there. Vascular tumors, benign. And so this is, I mean, I would have to think that most people look at this and think this is a pretty outdated slide, right? I mean, on its surface, we could be, you know, a decade ago and thinking, all right, in my clinic, I'm going to think of vascular tumors and vascular malformations. The tumors are the ones that are supposed to have a dynamic, prolific cycle. These cells were not necessarily supposed to be there, and yet here they are, and here they are expanding, where the malformations were supposed to be much more of the static errors in the development of a vessel. And yet, of course, we all know that these lines are quite blurred, that we have malformations that act more dynamically, and we have some tumors that are more static, you know, in some nature. But let's explore deeper into the quote unquote benign vascular tumors for today's presentation.
Okay, so we're going to delve into kind of the heart of the matter, discussing hepatic hemangiomas. And before we do so, I just want to pause for a minute to recognize some of our panelists. As you know, Dr. Nakano, myself, I'm Annie Kulongowski, and I also wanted to recognize Dr. Anam. We help coordinate the Vascular Anomaly Center here at home in our hospital at Children's Hospital, Colorado. Also want to make some slightly more formal introductions. We have Dr. Christy Rylon joining us as an associate professor of surgery and a pediatric surgeon at Baylor College of Medicine, Texas Children's Hospital. She wears many hats, also has an interest in colorectal surgery, but has a passion for vascular anomalies. So we have her with us and has a background specifically in hepatic hemangiomas. Dr. Leah Werley is an assistant professor of surgery at West Virginia, and also has an interest in colorectal surgery, but sent us a very interesting patient. And so Dr. Worley will be going through her patient later in the discussion. And then Dr. Tang is one of our homegrown. Dr. Elizabeth Tang is an assistant professor of pediatric radiology. She actually has a specific expertise in pediatric liver lesions and oncology, so we're grateful to have her walk us through some of the imaging characteristics. And Dr. Zavaleta, Vaz Zavaleta, is over here, kind of off screen, but on screen now, is also joining us, part of our vascular anomalies team here as well, but as an assistant professor of pediatric radiology and interventional radiology, and has an expertise in vascular anomalies and workplace inclusivity. And so we're very thankful to have a pretty broad panel group here to promote the discussion. So just to kind of dive in right away as we go through hepatic hemangiomas this morning, really want to highlight that what you see on the skin is also going on in the liver. And that the premise is that an infantile hemangioma can occur on the skin and also in the liver, and a congenital hemangioma can occur on the skin and also in the liver. And so that sort of when you see the infantile hemangioma on the skin, just some of the basic premises that we sort of talk about in vascular anomalies community, that infantile hemangiomas are very, very, I don't even know of any case really where they're seen antenatally. They follow a very predictable life cycle, and that they stain for GLUT1, which is a glucose-like transporter. So they're positive for that under a microscope. And here is an infant with multiple cutaneous infantile hemangiomas on the skin. And there can be two forms that occur in the liver, what we call a multifocal form and a diffuse form. And so moving into the sort of congenital type. So congenital lesions, we say, are fully formed at birth. So here's a patient who presents with a fully formed mass on the arm at birth. This was, day of life 1. Theoretically, if we had done a biopsy, this would be GLUT1 negative. You can see that by the first year of life, this tumor has, voila, disappeared. And that this can also occur as what we call a focal congenital hemangioma of the liver. And I know that terminology gets very confusing and cumbersome, but if, essentially we just want to be clear that we're talking about very biologically kind of equivalent tumors that occur on the skin and in the liver. And so I'm okay, so Dr. Tang, just wanted to see if you could tune in to help us discuss some of the congenital features versus infantile features of our hepatic hemangioma, and if you might be able to walk us through some of the basics of what we're looking for when we get imaging.
Absolutely. So it used to be classically in the radiology literature, when we talked about liver hemangiomas, there are some really key words that people think of: hyperechoic or echogenic on ultrasound, very T2 hyperintense on MRI, and with this arterial phase, peripheral nodular discontinuous enhancement, and that centripetally fills in as you get later and later in contrast phases on MRI or on CT. So that's classically been what's described, primarily in adults, which, as we know, is probably a different process. In children, however, with congenital and infantile hemangiomas, the more we learn, the cloudier the picture gets. Those features that I mentioned are, for the most part, relatively true for pediatric hemangiomas in the liver. But one thing I want to point out, and which is demonstrated by the ultrasound images here in the congenital hemangioma, is that actually on ultrasound, there's a much more variable echogenicity. So in fact, the majority of infantile hemangiomas are actually hypoechoic. And congenital hemangiomas can be heterogeneous, kind of like the bottom right image. For that congenital hemangioma, the two examples, the bottom right image there, it can be kind of heterogeneously hypoechoic and echogenic, or it could be generally hypoechoic. So it's more common for these hemangiomas that are in the infantile or congenital pediatric types to be actually be hypoechoic on ultrasound. What that means is it can be a little bit more difficult to use that as a distinguishing factor from the differential considerations of metastatic neuroblastoma or hepatoblastoma, because those can also be hypoechoic in either focal or multifocal, especially in the neonate. So other things I would use to differentiate include kind of a homogeneous T2 hyperintensity, like you see in all of the examples here on MRI. And again, that sort of classic enhancement pattern of peripheral discontinuous nodular enhancement on the arterial phase that fills in over time as you get to later phases on an MRI. That also applies on contrast liver ultrasound, which is becoming increasingly used in the pediatric population. In some ways, the contrast liver ultrasound can actually offer even better temporal resolution than an MRI and better spatial resolution on an MRI. So if an MRI comes up with sort of equivocal results, or if a child can't tolerate MRI, you might want to consider doing a liver contrast ultrasound first, because not only does that classic peripheral nodular discontinuous arterial enhancement happen on a contrast liver ultrasound, with the fill-in, you can actually see the centripetal fill-in better because you have better temporal resolution on a contrast liver ultrasound than you do on an MRI. There are caveats to what I'm saying, though. And it's because while the vast majority of infantile hemangiomas have that peripheral discontinuous nodular arterial enhancement, actually congenital hemangiomas on liver contrast ultrasound and possibly also MRI might have a more heterogeneous enhancement pattern than you typically classically expect. So just because it doesn't enhance in that classic pattern doesn't mean it's not congenital hemangioma. It just means that you haven't excluded it from being something else. Typically speaking, these, like I said, tend to fill in during the later venous phases. Congenital hemangiomas more than infantile hemangiomas tend to have, might have a little bit of delayed phase washout, particularly on the contrast liver ultrasounds. That can be a confounding factor. Why do I bring that up? Because with the differential diagnosis of hepatoblastoma or metastatic neuroblastoma in the infant, that washout feature is sometimes used to suggest that something could be malignant. So in situations like that, you'll have to consider the preponderance of the clinical data, including things like AFP level, other lesions that could be in the abdomen, and also all of the imaging features over multiple modalities to see whether or not you might be warranting biopsy. Another additional feature you can use on MRI to distinguish, not with any certainty, but kind of to help favor or disfavor, is diffusion restriction. Malignant lesions like metastatic neuroblastoma and hepatoblastoma tend to have more diffusion restriction than hemangiomas, either congenital or infantile types. But it's not a hard and fast rule. There is some overlap in terms of the degree of diffusion restriction in these types of lesions. One more comment I want to make on imaging. This may be more than you ever wanted to know, but I'm a radiologist, so I nerd out about this sort of thing. When we're talking about congenital and infantile hemangiomas in the neonate, because that contrast enhancement pattern is so important, you want to be using an extracellular gadolinium agent. So that's your classic gadolinium agent. You do not, in fact, want to be using the hepatobiliary contrast agent like Eovist or gadozetate is what it is generically. You don't want to be using that with the liver MRI, even though that's usually what we use in older people to look at liver lesions. The reason is because Eovist, because of its contrast bolus size and the way it's taken up by the liver cells, its contrast enhancement actually is not as pretty and distinct for looking at that early arterial phase pattern as an extracellular agent like like Gadovist or something like that. Dotarim, or now Vue, those are probably the most common and desirable in the pediatric population, Dotarim and Vue. Anyway, so just be aware that these are things that you can consider. And if in doubt, consider clinical correlation with serum testing and biopsy. Oh, sorry, one other comment. Hypervascularity, this is my final thing. Hypervascularity on Doppler ultrasound can be indicative of infantile or cutaneous hemangiomas, but they don't all look hypervascular. A minority of them can just have normal or minimally increased vascularity compared to the background liver. And so again, in those cases, you still want to rely on the other features to distinguish it from possibly hepatoblastoma or neuroblastoma. Any questions?
There's a few questions in the chat. A couple of them I think we can gloss over a little bit, but one of them I'm really interested in. So one of them just asks, what is the threshold for a liver ultrasound, which I think you addressed a couple times as you were speaking, and clearly as the least benign and informative, as you mentioned, in 2 or 3 different ways. I think we've kind of addressed that one. Another one was, what is the threshold to kind of do a biopsy on these lesions? And I think both in the discussion you just had and in the discussion we'll kind of get to that one a little bit too. But there's another one in the chat that I'm curious, because I've thought of this as well. The question is, what about the term hemangiomatosis, which was previously described, and it was described as having an atypical enhancement pattern. And I think, the reason I'm interested in this is, we get back to the idea of everything's a hemangioma, right? Everything on the radiographic side, the pathologic side, even the clinical side in the clinic is called a hemangioma. That is a vascular mass. And yet, specifically kind of in the hepatic imaging, I think here is another term that is used in 2 or 3 different ways and may be interpreted by 2 or 3 different people. So I wonder, briefly, maybe we could hear from a couple of the radiologists about this question of hemangiomatosis and the use of it.
I personally don't use that term anymore because we have some known patterns of infantile hemangiomas that are multifocal or diffuse. And I don't find that to be clinically useful, personally. I mean, you can just describe how many tumors there are and whether or not they're confluent or multiple.
And Dr. Zavaleta, I think.
I agree with Dr. Tang.
I agree with Dr. Tang as well. I don't think there's a much use for that terminology anymore, especially since we've kind of classified things down a little further.
I've seen it in publication in just the last year in titles of publication. I've seen it in reports, so that's why I think I harp on not just hemangioma, but hemangiomatosis, these terms that, keep coming up. Anyway, for the sake of time, Annie, please.
Okay. So, a lot of credit is due to the people who come before us with Dr. Steve Fishman and Dr. Emily Christensen-Legay, who really in earnest, and a lot of people from Boston Children's Hospital who really tried to create a classification system, the one that we're actually discussing today. In my infancy as an early vascular anomalist, it was really difficult to sort of come to terms with how to describe these things. And remember, this publication was in 2012, really at the kind of era of the beginning of genetics and how we can actually classify some of our vascular anomalies genetically. And so, we had a liver hemangioma registry established through Boston Children's Hospital, and we were able to really kind of delve into this current classification system where the focal lesions, really follow what you're seeing on the skin, right? Back to kind of what you see on the skin is what's going to go on in the liver. Patients with focal the congenital hemangiomas had no sex predilection. There were equal numbers of females and males when we found them in the liver. They were antenatally diagnosed. You can see the other two columns with the infantile form, the multifocal and diffuse had no antenatal diagnoses. Cutaneous lesions did occur in some of our focal or the congenital hemangioma variety, which is known also. In some patients, there can be congenital hemangioma and infantile hemangiomas occurring simultaneously in the same patient. And then none of the congenital hemangioma patients were hypothyroid. And so this is really began to speak to the different biology of a congenital hemangioma versus those infants with infantile hemangiomas of the liver. And this is, comes from 24 years ago, but this is also an endocrinologist at Boston Children's Hospital where, these patterns had been somewhat recognized that there was something going on with these patients who had the kind of what we now call multifocal and diffuse forms of infantile hemangioma. Well, Dr. Wang was able to find in his lab that the infantile form of hemangioma makes a type 3 iodothyronine deiodinase that will convert your active T4 into inactive thyroid hormone. And so these babies can become profoundly hypothyroid, which is one of the distinguishing features, especially in the diffuse form of infantile hemangiomas in the liver. Most of those patients, we can go back, review at your own leisure, but most of those patients who have the diffuse form are also profoundly hypothyroid. And so I have Dr. Rylon here to sort of discuss some of the ongoing kind of findings from the liver hemangioma registry. And so, Dr. Rylon, if you want to tune in, just discuss some of your findings. I know these things are kind of a part of history now, since they were, 9 years ago, but I think it's important that we kind of understand, the role, how we can help our patients with, screening.
Yeah, and I followed in Annie's footsteps in Dr. Fishman's research lab. And this concept of screening had come from a paper from Cincinnati before, and they had recognized that if you have 5 cutaneous infantile hemangiomas, that you had a greater likelihood that you would have hepatic hemangiomas. So what we looked at in the liver registry was all of the patients who had cutaneous lesions and who had been screened or not. And 60% of them had been found through screening. And we looked at the outcomes between those who were screened and were not. They were able to identify the disease earlier, and the patients who had these multifocal and diffuse hemangiomas actually had less complications, and we had 0 mortality in that screening. So I think just supports this concept that when you do have 5 cutaneous lesions, you should obtain a liver ultrasound. And I think that partly answers the question in the chat about what the threshold is, and it's about 5 lesions when you should. Oh, Annie, you're muted.
Sorry, I'm trying to minimize the rebound sound here. I think that the literature suggests that about 20% of patients will have, if you have 5 or more cutaneous infantile hemangiomas, I think the data suggested 20% of the time you will find an associated liver hemangioma, and that's specifically infantile, the multifocal or diffuse form. And then I wanted to I know this is kind of going a little bit back and forth, but if Dr. Tang or Dr. Zavaleta or Dr. Anam had any kind of commentary, these are specific kind of ultrasound images of the two congenital and infantile hemangiomas, if there were any comments. And at the bottom left is kind of what a residual, in my mind, congenital hemangioma looks like after involution. Any commentary, Dr. Tang or Dr. Zavaleta and Dr. Anam?
Well, I think these are both really beautiful examples of the hypervascularity you can see with color Doppler. It'd be really hard to confuse this with hepatoblastoma or neuroblastoma in either of these Doppler cases, because it's just so markedly hypervascular. And, you know, the involution creating that calcification is an expected evolution as they sort of recede. Occasionally you can get that calcification before, like it can be pre-existing in maybe 20% of some of these congenital or infantile hemangiomas, or less than that. And so that might be a confounding factor. If you saw it before treatment, that might prompt you to wonder if it's a malignancy. But in the absence of calcification, you could probably feel pretty confident that these are all hemangiomas.
Great. And I put this chest X-ray up also just as an example of, you know, this is a patient that our very astute nurse practitioner had a patient come. Ultrasound showed this, and she's like, this baby doesn't look so great, sent them for a chest X-ray, trying to sort of work this up, and the baby had, you know, looks like some degree of heart failure. And then this is just the liver after all of the infantile variety have involuted.
Yes, very nice example of cardiomegaly and probably some shunt vascularity.
And Christy was able to delve even further into the registry and really was able to highlight some of the risk factors for these, the specific infantile hemangiomas of the liver. So I'll let Christy kind of talk about her findings here.
Yeah, and again, as Annie mentioned, we were doing this work, it's like 10 years ago. So I think we knew a lot less, and propranolol wasn't being used as often. So we had a significant amount of patients in the registry with multifocal and diffuse hepatic hemangioma who actually died. And so when I looked back to see what the risk factors were for mortality, what I found is that the diffuse lesions were much more severe, and those had a lower survival. And then the patients with congestive heart failure also had a lower survival. And then in the diffuse population, it's important to note that many of those patients died from abdominal compartment syndrome, which is a clinical diagnosis. So it's important to, you know, have early involvement of a surgeon so that they can make that diagnosis and treat, because those were the patients that had very high mortality in this group. I think now that we know a lot more, we see that much less, but in, you know, 10, 15 years ago, these were why patients were dying, either from congestive heart failure or from abdominal compartment syndrome.
So we're going to turn this now over to Dr. Werley to go through a very interesting case. So Leah, I will help guide the slides for you.
Okay, thank you very much. Yes, I wanted to thank I wanted to say my thanks to the team in Colorado Children's Hospital as well as Boston, since they helped us guide us through those last couple of months with our patient. So she was born, it's a female baby that was born prematurely at 30 weeks and 6 days due to concerns of fetal distress. Her prenatal ultrasounds at 20 weeks were normal, so no findings there, especially no lesions were seen within her liver. And as you already can imagine, it's probably about hepatic hemangioma since you're here. And during her clinical exam after she was born, she was in respiratory distress, so she got intubated, and a very distended abdomen was noted. The abdomen was soft, so no concerns for abdominal compartment syndrome at this time. But it prompted the NICU attending to get a KUB, as you can see here on the right side. You can see the bowel gas all shifted to the right lower quadrant and more or less gasless abdomen on the left. Her hemoglobin at birth was 9, so she received 30 mL per kilogram of packed red blood cells. Next slide, please. She further then was worked up with an ultrasound of her head, which showed, due to, she was prematurely born, a grade 3 bleeds within her brain bilaterally. Her ultrasound of her abdomen showed a large hepatic mass, which measured about 6.4 by 8 by 5 centimeters on ultrasound. This prompted then further workup with an MRI, which we're going to see shortly. And her echo was concerning for high output heart failure with a still low normal systolic LV function and mild mitral valve insufficiency. So she underwent further workup with an MRI. Next slide, please, which showed a large left hepatic lobe mass of 4.0 by 8.3 by 7.6 centimeters. And additionally, several smaller lesions were seen within the right hepatic lobe, as shown on these 2 images. And on the next slide, you can see that these, especially the large lesion, shows avid early enhancements within the periphery, within the main lesion. And our radiologist felt strongly about that this is most likely a hepatic hemangioma. She then had further workup. Labs were drawn due to the differential diagnosis of neoplastic lesions, mainly neuroblastoma or hepatoblastoma. Her anemia improved after she got transfused. She had a transient thrombocytopenia with a low fibrin that was transfused as well. And I'm going to show you a graph how it developed over the course. Her coags were normal, her thyroid function, she never had any signs for hypothyroidism. Her liver enzymes and her bilirubin were normal, but her AFP was highly elevated with over 200,000, and her beta HCG was normal as well. Homovanillinic and vanillinic mandelic acid were normal, so there were no, or it was not concerning for neuroblastoma. When you look at the graphs, you can see that her platelets kind of dropped on her day of life 3 to 46, but recovered within the next couple of days and kind of stabilized out throughout her further clinical course. So she did not require any other transfusion for her platelets. Her alpha fetoprotein kind of normalized over the course of 6 months. And Dr. Nakano wanted to show this slide as well for her, or for serum AFP changes over the course in neonates, and I'll let you comment.
I think it's an important point, as kind of the hemonc representative in the group. Obviously, the baby comes in, there's a big mass, there's a differential. Ideally, our radiologic colleagues are honing in on a more benign yet clearly clinically impactful lesion. And then you get this alpha fetoprotein that, that's through the roof. And yet remember that you had a preemie, a 20-week-old, so that the child, typically the normal levels you are measuring that your lab is giving you is a term baby, And, if you look at the 95% interval here, as far as where a child could be at birth, you're still not too far off, And I guess the point I would make is, 2 points in time is better than one. By the second time point alone, you were dramatically more comforted with your alpha fetoprotein. By the third time point, you were very much, more comfortable with your alpha fetoprotein, and so it is a number that is difficult to interpret in isolation, and yet, but even a second time point dramatically improves, kind of how you feel about this being a germ cell tumor marker versus just normal progression of alpha fetoprotein in the child. So hopefully, just not to interrupt too much, helpful to see that actually quite pleasantly how this normal curve matches the curve you just showed, for your patient in natural progression.
And then I also, sorry, don't want to interrupt Leah too much, but I also wanted to interject here too, because, from we as surgeons and hematologists, interventional radiology team, and our radiologists who were sort of hounding for what do you think this is? Just some of the early kind of pathophysiology, and I'd love to get Dr. Ryland's opinion on this too, is, this thrombocytopenia, the anemia. Thankfully, this baby's coags were normal. And, kind of what do we think that is from? I'm a pretty simple person. I always have explained this, and maybe this is just from teachings during my kind of learning of vascular anomalies. But I think of this as that all of a sudden, the baby is now out of the uterus. There's a bit more opportunity for the lesion to kind of no longer be compressed, and the changes of blood flow really directed through the liver. Even on the skin, you can see these changes on big cutaneous congenital hemangiomas, where there's this very transient thrombocytopenia, anemia, and sometimes mild coagulopathy that I really do think is from intralesional bleeding, and it's not bleeding, but intralesional kind of altered blood flow right into the tumor that happens in those first sort of 24 to kind of 5 days of life. And I just want to be, distinguish this from what we also very loosely apply this term called Kasabach-Merritt phenomenon to Kaposiform hemangioendothelioma, in my mind, is the only tumor that we should really be applying this phenomenon of Kasabach-Merritt phenomenon. I use...
No, I would agree with that.
Okay.
I would absolutely agree with that. I think it's a good teaching point, because I do think the Kasabach-Merritt phenomena as a term is overused. It's very uniquely this rapid consumption of platelets and fibrinogen, and this cycle that you see in these KHEs of hyperfibrinolysis that just chews and chews and chews. I do think you're completely right that there is a elevated dimer, a mild thrombocytopenia in the congenital hemangiomas, and yet is not that same vicious consumptive cycle. It may still border symptomatic, but it's not necessarily the same vicious cycle. Christy, do you have any thoughts?
Yeah, no, I mean, I think Annie's exactly right. And this is something that's still in textbooks, that when you have a liver lesion, you can get a Kasabach-Merritt phenomenon. But I think it's really important to point out that it's only in KHE where you see that phenomenon, where it's very severe. And I like the graphs that Leah showed, where you can see the platelets normalize. It's just important that you do have to transfuse, but you're not going to have the same coagulopathy that you see in KHE. And I think the other important point here is about the AFP, because often as surgeons we're asked, is this a hepatoblastoma? Do I need to resect? It's important to know what is a normal AFP and what is not, and to trend that, because they can be very high in these hepatic hemangiomas, but they're not as high as hepatoblastoma. So it is important to trend. And if you're not sure, you can always go to a biopsy, because it is really critical that you distinguish the hepatoblastoma versus a hepatic hemangioma.
And I empathize with the NICU in this case, as far as this is a baby that's a preemie that I think you said had an interventricular, hemorrhage of some degree, and this mild coagulopathy where I would say, you know, keeping up the fibrinogen prophylactically, you know, greater than 100, it's a small amount of, you know, you can use cryo with a small amount of fluid. It usually doesn't throw the baby's equilibrium too far off. How much fluid it is to keep the platelet count up? I mean, NICUs are usually pretty liberal to keep the platelets above something like 20,000, 30,000 if the head is involved, you know. You know, but this certainly isn't a disseminated coagulopathy, but you empathize with knowing that there was a bleed in the head.
And
That's, sorry.
I also
One-
think that Dr. Whelan actually also touched upon, just to answer that question earlier about biopsy, just that if you're not following the actual standard, very classic imaging kind of pattern and labs, then, you know, you want to actually consider biopsy in that picture.
So we don't want to steal Dr. Worley's thunder here, so.
Well, as everybody already mentioned, it was really kind of hard to, since remember she was a premature baby at 30 weeks and 6 days, so by the time now 31 weeks, and we reached out to, again, Children's Hospital Colorado and Boston to have this patient discuss, look at the images, and our team here felt strongly to start treatment with prednisone and propranolol due to concerns that the patient could go into cardiac heart failure or cardiac failure. So we started her on that treatment, and she's still on propranolol up to this day. And next slide, please. Then, as you already saw, some of the curves, her clinical course on day of life 5, her echo normalized already. There was no signs for that she could go any further with, I mean, her ejection fraction normalized. On day of life 21, so 3 weeks later, 34 weeks then, she had additional 10 lesions within her right hepatic lobe, besides that already known large lesion. And so our team here, again, we discussed it with Boston and Colorado. A biopsy was recommended, but due to her age and her weight, which was less than 2 kilograms, we were worried to get a biopsy at this point, and therefore treated her with propranolol, prednisone, and did ultrasounds quite frequently to see if any of those lesions would change or grow further. It's still planned to get a biopsy, actually end of this month, to confirm diagnosis. It's unusual, the presentation, that she has one large lesion as well as several smaller ones, and I would like to have your opinion as well. But the idea is to get biopsies of those lesions to confirm if it is a congenital or infantile hemangioma, or even if they could you know, happen concurrently, meaning that one is congenital and the other is infantile. So
Let me ask a question to Annie and any of the surgical folks on the call. You know, how excited are you to go into this belly, you know, and get a biopsy? So let's say I come to you, you know, I say, you know, propranolol, even if it's infantile hemangioma, is not going to work overnight. You know, we don't want to get too far behind, hanging our hat on a therapy that's going to take weeks, and yet the heart is not loving the situation. Pluses and minuses of how excited you are to go into this, you know, belly and get a biopsy, and or, you know, as far as, I guess it's both a surgical and radiographic, you know, as far as you may just be as equally less excited to poke this, you know. So maybe we'll start on the surgical side and then we'll go radiographic, but what are the pro cons of you guys going in there?
I mean, so I would not be super excited.
I would not.
You know, I would go very hesitantly towards biopsy. And I guess, you know, back to some of the principles of just the imaging, the labs, you know, trying to sort of sort this out. This is also why I thought this was a really interesting case, because it does create a bit of a conundrum here, in the sense of, you know, congenital hemangioma and infantile hemangioma potentially in the liver. And it makes it definitely more confusing. So I don't know, Dr. Rylon,
I wouldn't be excited either. I think especially if there's any sort of coagulopathy and our techniques are a little bit more invasive. And when you get into this parenchyma, it can be very difficult to stop the bleeding. So I think these percutaneous techniques where you can glue the tract where you biopsied are really nice, which is why I think we've moved away from a surgical biopsy to these percutaneous techniques. So certainly I myself have not done a liver biopsy I can't even remember when, because our radiologists are just so good at it.
So if we did go percutaneous, Anam, Tang, or Zavaleta, you guys what?
maybe since Dr. Zavaletta's here, would you want to comment on?
Sure.
You want to take this on?
Sure. I mean, if everybody agreed that we needed to move forward with the biopsy to get tissue for confirmation, then I would agree a percutaneous needle, image-guided percutaneous needle biopsy would be, still has the risk of bleeding, but significantly less risk than an open biopsy that the surgeons have already commented on. We
Right.
could use gel foam to close the tract as well. And so we could probably do this pretty safely.
And just to also add to that, I'd say I wouldn't be excited about doing it either. Just to confirm all of your fears, I think that we all would have that same kind of concern about hemorrhage, but I do think we could probably biopsy this safely. You would need cores. You wouldn't, an FNA or something would not be sufficient. So you actually do need some solid tissue there to make a diagnosis.
Yeah, thank you. And then I think the questions we can a little bit because we don't have a ton of time left, move through kind of, some of this as we continue the discussion moving forward. So thank you, Leah. And please, we'd love the follow-up after the biopsies come back of what's going on. And if it's true that there are two distinct forms of hepatic hemangioma in the liver. I don't know, Dr. Rylon was using the data set. I mean, now it's been a decade plus, but I never came across one in the data. So I think it made me really kind of wonder, is this possible? But it's possible in the skin, right? We definitely have seen it. So thank you.
Thank you.
Just moving a little bit, into the congenital, what we call the focal form. I think Dr. Wehrle had this on her last slide, kind of observation, embolization, do you biopsy, do you resect this, or do you move towards transplantation? I have these pictures. These are old. This was actually kind of my, in May of my fellowship. This was a baby born who actually did have a true focal congenital hemangioma of the liver that had just horrible heart failure. It was embolized, really did not respond, and moved forward to resection, and is now, I guess, 12 years old and still doing very well. Obviously, we did not want to have to do this, but it made him better because he was not going to survive. And I know that there are other cases when these congenital lesions can occur kind of around hepatic ducts where they cause obstruction and other things that can be very challenging to manage. And Dr. Zavaleta, Dr. Anam, any kind of commentary on how you would do embolization techniques for this?
Well, embolization for these, I can say for just a bland embolization, I haven't really found to be as helpful in terms of shrinking these down. And I can't say I've done hundreds of these, but the couple that we have seen just not as helpful with that. However, there is reports in the literature for these patients that sometimes we see older patients that we actually find these later and they're greater than 4 centimeters. Sometimes you actually can do a bleomycin lipiodol embolization. But these again are older patients. I've seen the case reports for. I can't say necessarily this would be the right thing for a neonate. But that's some information that's out there. You could also do that with some PVA particles or embospheres to try to shrink this down. But again, bland embolization, not as successful as I'd hoped.
Yeah, I would just say the same thing. I don't have a lot of experience with embolizing these at all, but in the literature, in addition to in older patients, in addition to embolizing intraarterially with bleomycin, they've also reported percutaneous embolization of liver masses with bleomycin. It's challenging either way.
How do you guys feel either the surgical or intervention approach, the impact on the remaining liver? I mean, I look at these, you know, we get a consultation, they show a picture. It's like 80% of the liver is some kind of tumor if it's a congenital hemangioma and or riddled in an infantile hemangioma. And you wonder, you know, what is left, you know? And then I'm always surprised when you do liver functions and they're actually fine, or the synthetic function of the liver is working and you're like, way to go, 20% liver or 10% liver, you know, but, you know, post a procedure surgically or interventionally, you know, what is the feeling of the impact long term on the liver itself, you know, and its ability to not only produce what it needs to produce, but have bile go where it needs to go, you know, thoughts surgically or interventionally?
I mean, you can, the liver, you need very little liver if it's, so long as it's healthy, like 20% is probably enough and it regenerates. And so they can do that's what you need. It's not this, you know, in adults, when they're alcoholic, you need a lot more, but in these kids with healthy livers, you can remove 3/4 of the liver and they'll be fine.
Yeah.
Oh, and I forgot to put up here, and I don't want to make this too controversial, but at ISFA this year, and you know, I forgot to put pharmacotherapy here as a kind of a list, right? Because, and not really, we haven't delved into it, but you know, theoretically, if you did a biopsy, this would be GLUT negative, right? GLUT1 negative, and then GNAQ or GNA11 positive from a, you know, a genetic point of view. There is some discussion, Dr. Nakano, sirolimus was kind of touted this year as an option for these congenital hemangiomas. Thoughts?
Yeah, I mean, what haven't we thrown rapamycin at, you know, now? I mean, it's 15 years experience. At the very least, you could say we know its risks. We know how to dose it well, monitor it well, and do it safely. And so if you approached us with the scenario where the heart is in failure and the child has, you know, very little other options, yeah, I think that we would probably be willing to do it. How much evidence we have that in a timeline that is productive, rapamycin is going to make a difference, that's hard to say, but I could probably wield it safely. Same thing with the propranolol question, you know, as long as the cardiac group said that we weren't doing anything negative to the system by having a mild, you know, blood pressure medication on board, you could see under, you know, critical situations why not knowing if it's infantile or congenital hemangioma, why a trial and that's diagnostic and therapeutic at the same time could be reasonably productive. But, you know, I think dawning of the age is we need to do this prospectively. We need to do this as a united community, standardizing our approach and doses. And I'll stick with that answer. There are a couple questions about, you know, what about laser therapy? What about ligation of the hepatic artery? There's a couple different approaches that people are saying, you know, are there multiple ways to go after this? Any thoughts on anyone that's heard of the role of laser, or I guess more of an interventional ligating the hepatic artery itself?
I guess the question of laser, is that for skin?
Yeah, I don't
Laser-
have.
Because laser treatment, I mean, as an ablative modality in the liver is mostly used for like very small lesions, less than 2 centimeters in diameter. So I don't think that laser has a role for liver hemangiomas. As far as ligating the hepatic artery, I'm gonna defer to Dr. Anam on that. I don't have any experience in the literature or practical with ligating the hepatic artery for hepatic hemangioma.
Not for a large congenital hepatic hemangioma, but for infantiles, I've seen that just because I think there was some shunting within those lesions causing significant cardiac failure. So we have done that with ligating the actual hepatic artery, and hopefully that shuts down your blood flow and these shrink down. So it's kind of a pretty aggressive measure to do that, but now you're risking a baby that is, could also die from CHF. So it can be done, but I think there might be other ways that you can successfully treat these hemangiomas where you don't have to be as aggressive. At least these days we can.
Annie, you're gonna do the guideline paper. Is that, we have a slide on that one?
Yeah, we have a slide on the consensus here.
I would do that. We only have like 5 minutes, so I would at least mention the effort. I mean, it's a few years. It's a few years into that publication, but at least you can mention some of the colleagues that came together for that one.
Yeah, so just kind of trying to wrap this up for everyone. This is just an infantile multifocal form. This was one of our own patients who was really, really sick and did have to undergo some embolization of some shunts for a larger multifocal form of infantile hemangioma. And this is actually an intraoperative image because she required a G-tube. And I thought it was a beautiful picture of just what it looked, what this looks like in real life, right? Because we don't always see these. Occasionally you'll find them incidentally. And I'm sure Dr. Rylan has had partners or her own, own operating where you take a baby down and you're like, oh, look. Because sometimes we don't even know that these multifocal lesions are in the liver and they're found incidentally at the time of laparoscopy for something else. This is my personal bias. I don't think I've ever done a biopsy of one of these infantile, because I think the imaging pattern usually is less confusing. And I have personally never done a resection for these, but I'm sure there are cases. And then, just this is a picture of another very sick infant with the diffuse form. You can see, the body is covered with cutaneous infantile hemangiomas and the liver is full. And this is, pretty typical appearance of how a baby may look with an abdominal compartment syndrome. And then just to kind of summarize here, I know this is a really busy slide, but it can be a reference for all of us really just about, kind of people who, physicians coming together to really try to get consensus on how to recommend kind of following these and the terminology that we're so that we're all talking about the same lesions when we are discussing these hepatic hemangiomas. And so just, here, this is just a slide, congenital versus infantile. And then I really like this next kind of specific recommendations. This is really kind of how things to look for and ways where you can follow along just with serial ultrasound, thyroid function testing and echoes. Dr. Werley's group did an expert job following the labs and serial imaging. I reviewed the paper, just in preparation, and unfortunately there was no consensus on the interval for which you should follow with ultrasound. I don't know what you guys do, Dr. Rylan, but we kind of, try kind of every 6 to 8 weeks based on how the patient is doing clinically.
Yeah, I start spacing them out when it looks, if it's pretty stable. Of course, for like a diffuse or if it's multifocal with some congestive heart failure, I might do it more frequently, like you said, every 6 to 8 weeks.
And then I know we've kind of run out of time, but Dr. Nakano, any last minute?
No, I really appreciate you putting up that last effort. I see Jana Jakobush, who's the first author on the paper here. That was a really collaborative effort, the spirit of ISFA, the spirit of MAVA, the spirit of what we do, multiple disciplines coming together at the same table. I remember when they did that, and just seeing, again, the hematologists with the surgeons, with the interventionists at the table, and coming up with what they could agree on and coming up with the areas that were worth publishing that couldn't be agreed on. And that's all we're trying to do here, to take the steps forward. Really want to thank everyone for joining us. This is so exciting to be back. All of our guests, thank you so much for taking the time. I think because we're always up against the clock, it says we should probably come back and do more. There are a lot more lesions to go through. There are a lot more questions. Anyone out there that has questions, please feel free to send them. We've always welcomed international cases that we can collaborate together. We'll try to match guests to the topic of interest. And then, I think we have a goal to come together early next year to have another MAVA. But until then, thanks to the Hendren Project for having us. And hopefully everyone has a great day. Thanks so much.